I'm here to share my experience with the Nclex and also to share with you some tips when answering Nclex questions. Okay, so feel free to ask me if I don't have the answer right away. I'll get back and review, and for sure I'll get back to you. By the end of this review, I'll be sending you some materials by email, or either I will post it here in the chat that you can review and just to get ready for the Nclex. Today we'll be talking about prioritization and delegation, which is an important part of the Nclex. I think maybe you're gonna have at least 15 questions for prioritization and delegation in the Nclex. All right. Okay, Joan, you let me know when I can
Yes, you can
start.
start it. You can start
Okay,
it.
perfect. All right, so we're gonna talking, as I told you, we're gonna talking about prioritization and delegation today. And the first hint I want to give you guys is not to use ABC, uh, by ABC meaning airway, breathing, and circulation, in those questions unless the answers does not have a modifying phrase. And you're gonna see moving forward in this presentation, you're gonna see what is a modifying phrase, um, and why I don't want you to use ABC in those questions. If you're clear when to use ABC, you can go ahead. But if you're not clear when to use it, you just have to follow the tips that I'm gonna give you today. Okay. Usually, the prioritization questions have four answers, and the answers are usually about four patients, and they give you the patient age, the gender, the diagnosis, plus a modifying phrase. Two things that you can immediately rule out from those answers are the age and the gender. It doesn't matter when answering a prioritization question. It doesn't matter if it is a 1-year-old boy or a 70-year-old female, okay? And it doesn't matter if it's a transgender or if it is a male or whatever sex, or whatever age the patient is, okay? What I want you to pay attention is to the diagnosis and most important, the modifying phrase. For example, if I ask you to prioritize between angina versus myocardial infarction, which condition or which diagnosis would you go first? Would you prioritize between angina and myocardial infarction?
Myocardial.
Of course, for sure, myocardial infarction. And here we have one of the four rules, the first rule for prioritization, which is acute beats chronic. Everything that is acute, you have to prioritize over the chronic conditions. Okay, angina is a chronic condition, and myocardial infarction is an acute condition, so you prioritize myocardial infarction over angina. But if I tell you angina with unstable blood pressure versus myocardial infarction with stable vital signs, which one would you prioritize?
Unstable.
Unstable. And I wanted you to pay attention to that word. It is very common on Nclex. Okay, if whenever they say unstable, stop there, read the question, and go with that answer. You always prioritize unstable patients versus stable. Okay, and you see here that angina, no matter what, angina is a chronic condition, but the modifying phrase, okay, the phrase that is modifying the condition said unstable blood pressure. So you're gonna pay more attention to the modifying phrase than the diagnosis. Okay, the second rule: fresh post-op, fresh post-operative. And when I say fresh post-operative, I mean the first 12 hours of whichever surgery, no matter what surgery, the first 12 hours are critical. So fresh post-operative beats any other medical or any other surgical condition. Okay, the first 12 hours of a postoperative patient are vital, so you're gonna prioritize those patients. The third rule we just talked about that is unstable beats stable, so you need to pay attention more to those unstable patients when prioritizing. And the fourth and the last one is the more vital the organ, the higher the priority. And you're gonna see, if I give you COPD, and I want you to pay attention to here, COPD, congestive heart failure, appendicitis, 2-hour postoperative cholecystectomy, and 3 days postoperative CAB, coronary artery bypass graft. Which one between those five would you prioritize? And it is pretty easy. It's already highlighted on red.
It's 2 hour.
The 2 hours postoperative cholecystectomy, which because it is in the first 12 hours of a postoperative. If we were to go in with the ABC here, which one would you prioritize? If we were to use ABC, airway,
COPD.
breathing and circulation, the COPD, right? And then you got that answer wrong. Okay, that's why I don't want you to use ABC in those questions. All right. So I'm here, the fourth rule that said the more vital the organ, okay? I want you to pay attention. The more vital organ, the number one is brain. Everything related to brain goes first, okay? Second place, lungs. Third place, heart. 4, liver. 5th, kidneys. And 6, pancreas. And if you pay attention to that order, you can see that it goes cephalocaudal, okay, from head to toe. It is pretty easy to recognize that, okay. If we go from head to toe, brain goes first. If we go a little bit down, then there are the lungs, then the heart, the liver, the kidneys, and the pancreas is an exception, but it's the last one. Okay, so brain first, pancreas the last one. Okay, and I want you to ask, who is the highest priority between a 23-year-old male with congestion?
You're muted.
Professor, you go mute.
I'm sorry, guys. Okay, I was telling you and I was asking you, between the three options that we have here, who is the highest priority? It is already highlighted. I just want you to pay attention to the modifying phrases, as I said. A 23-year-old male with congestive heart failure with potassium of 6.6 and no ECG changes. What is the modifying phrase here? What is it? No ECG changes. That is the phrase that modify, okay? This answer, no ECG changes. The patient has the potassium pretty high, but has no ECG changes. Okay, chronic renal failure with creatinine of 20.7 and pink frothy sputum. Okay, what is the modifying phrase here?
Chronic.
I'm sorry?
Pink frothy sputum.
Pink frothy sputum, that's the modifying phrase here.
Lung edema.
And it is related to which organ?
The lung edema.
Lungs, of course, lungs. Okay, so we're gonna stop here, okay? Here we have a lung problem. But then, see the last one, acute hepatitis with jaundice, an increased ammonia level, who you cannot arouse. What is the modifying phrase there?
Uh,
Who you cannot arouse.
Who you cannot arouse. So the patient is not arousable. What
comatose.
does it mean? What does it mean for you?
Comatose.
Exactly, the patient is comatose. So, and coma is related to which organ?
Brain.
Brain, and brain goes first. So between those three patients, we are gonna prioritize the patient that you cannot arouse, okay? Because brain goes first. Here we have a table with some keywords that they can give you in the answers, okay? And I want you to use that, and I want you to remember that when answering those questions. Stable. We have in the left side, we have stable, and in the right side, we have unstable phrases. Okay, first of all, and obviously, stable. Whenever they say the patient is stable, guys, don't make science. Okay, don't try to get something that is not in the question. Okay, because sometimes we said, okay, that patient is stable right now, but he can decompensate in the next 5 minutes. And this and this can happen to that patient. Don't do that when answering a question. Don't do that. Go with exactly what the patient says to you. Okay, if they're telling you that in that moment the patient is stable, the patient is stable, and that's it. Okay, you immediately rule out that option. Okay, the other word is chronic. Whenever you see that the patient has a chronic condition and doesn't have anything else that is modifying that chronic condition, you rule out that option immediately. Postoperative, more than 12 hours. That patient is immediately stable. You can rule out that option too. Local and general anesthesia. Okay? Local and regional anesthesia, you can also rule out that. It is not a major issue. Whenever they say the patient is ready for discharge, okay, and the nurse has to see that patient. Give me just a second, guys. Hold on. Okay. All right, guys. Admitted more than 24 hours. Whenever a patient is spending more than 24 hours in a hospital setting, you have to realize that that patient is stable. Okay. An unchanged assessment. What does an unchanged assessment mean? Tell me.
It stays the same during and after admission.
Sure.
The,
Good.
the vital signs
The vital signs are stable, for example, since admission, or unstable. It could be that the patient was admitted for high blood pressure, and the patient still have high blood pressure, but nothing else has changed. Okay, the patient hasn't developed any muscle weakness. The patient hasn't developed anything else than high blood pressure. An unchanged assessment, that patient is considered also stable. Okay, and expected signs and symptoms. What are expected signs and symptoms? Expected signs and symptoms are those group of symptoms that you expect to see in a certain condition. For example, tell me what are the expected signs and symptoms for, let's say, diabetes mellitus. What do you expect to see in diabetes mellitus?
High blood sugar.
I'm sorry?
High blood
Hyperglycemia.
sugar.
High blood sugar, okay. Hyperglycemia. What else? Polyuria,
Polyuria,
polydipsia,
excessive. Yep.
excessive thirst,
Dehydration, hyperkalemia.
dehydration. Okay, those are expected signs and symptoms. So that patient is considered stable. Okay, now in the other side, we have unstable hints, and that's what I need you to pay attention to. Okay, whenever they say your patient is unstable, the patient is unstable, and that's it. Don't try to make science with that. If they say that patient is unstable, go with that answer. Okay, acute. Anything that is acute is unstable. And I want to stop here and I want to make an exception for asthma. Is asthma a chronic or an acute condition?
A chronic.
Exactly. Asthma is a chronic condition. But what about an asthma attack? Is that
That's
chronic or
acute
that's
episode.
acute? Okay, that's acute. That's what I want you to pay attention. Okay, a patient can have angina. Okay, but an acute angina episode is considered acute. Okay, that's the patient has a basal condition, but is developing an acute episode. Okay, general anesthesia. Whenever a patient is under general or going out general anesthesia, that patient is considered unstable. Whenever they say that patient is not ready for discharge, that patient is also unstable. Okay, a patient that is admitted less than 24 hours, the first 24 hours of any admission is considered unstable. Okay, any change in the assessment, is considered unstable, and also unexpected signs and symptoms. And I just realized that I wrote symptoms bad there. Okay, but don't pay attention to that. Okay, unexpected signs and symptoms. Whenever they give you something that you say, okay, hold on, this is not expected to be seen in this condition. Okay, the patient has high blood pressure, but he has a left side weakness. That's not expected. Something else is happening here. So the patient is unstable, and you need to be careful. You need to pay attention to that answer. Okay, read the question again. Okay, and go with that answer. Now, who is the higher priority between a 16-year-old female with meningococcal meningitis who has had a temperature of 103.8 since admissions 3 days ago, and an 80-year-old male with irritable bowel syndrome who's peaked a temperature of 100.3 this afternoon?
The
80-year-old.
The 80-year-old male, okay? Of course. Why? Tell me why.
There's been a changes in the vital signs.
There is a change, okay? And that also is, it is expected to see fever in irritable bowel syndrome. It is expected or unexpected?
unexpected.
It's unexpected, okay? It is not common to see fever in IBS. So here we have that the patient has started with fever, okay, this afternoon. So that's what? A changed assessment. Plus that fever is unexpected. So we have two factors here, okay, to go with that answer. And you see that meningococcal meningitis could involve the brain, okay? But if we pay attention to the modifying phrase, the patient has had a temperature of 103.8 since admission 3 days ago. So that's an unchanged assessment, which is also expected or unexpected to see fever in meningitis, in bacterial meningitis.
Expected.
It's expected. So we can immediately rule out that. Do you see how you can get the answer right? Okay. Regardless of meningococcal meningitis could involve the brain, the right answer is the other one, the 80-year-old male, because it had an unexpected change. And what else had the patient? A change assessment, I'm sorry, an unexpected sign and symptom. Okay. So, and also always has highest priority over others, no matter what, guys, no matter what else they are giving you in those answers. And they're gonna never put this together. The Nclex never, ever will put hemorrhage in one answer and hypoglycemia less than 7 in the other answer, because you cannot prioritize between hemorrhage and severe hypoglycemia. Okay? Pay attention to this. If you're able to memorize this, whenever you see those that options in an answer, you're gonna get it correct. Hemorrhage, fever of 105 or higher, because anyone, not only children, anyone with fever higher than 105 has a high risk of seizure, okay? And seizure is related to the brain, and brain goes first, okay? So hypoglycemia less than 70, it is also, okay, a critical value. And whenever they say the patient is pulselessness, breathlessness, or with fixed dilated pupils, whenever they say the patient is pulselessness, breathlessness, or with fixed dilated pupils, you go with that answer, except they're asking you to prioritize in mass disasters, okay? Because those patients are black tag code. Do you understand what I'm telling to you? If they're asking you to prioritize between 4 patients, they usually give you 4 patients to prioritize among. So if they're asking you to prioritize between 4 patients in the emergency room, okay, you go with this. Now, if they're asking you which patient would you take to the hospital in a mass disaster, do you need to transport a patient to the emergency room? Do you need to transport a patient that is the highest priority or the less priority?
The ones that are fixable, but not like the black tag one, for what I understand,
Yeah.
they don't go to the hospital because they're gonna die anyways, regardless of anything.
Perfect. That's what I wanted you to notice, okay? If you are in a mass episode, in a mass disaster, and you need to transport patient to the hospital, guys, never take the patient that is a black tag or a black code to the hospital, because that patient is gonna die. Okay. Now, delegation. There is a general rule for delegation, okay? And I want you to memorize that. Do not, you as an RN, as a registered nurse, do not delegate what you can eat. And by eat, meaning evaluate, assess, and teach. Okay. A registered nurse never, ever delegates an initial evaluation, an initial assessment, or patient education. Okay, that's within the scope of practice of the registered nurses. And registered nurses cannot delegate those tasks. So let's see, LPNs cannot start an IV, hang or mix IV meds, push IV meds, administer blood products like heparin, erythropoietin, plasma, platelets, total blood pack. Hello? Hello? All right. So that is an RN task to do, not an LPN, okay? Not a licensed practical nurse. LPNs cannot also take care of central lines, no flushing, no dressing changes of a central line. That's also an RN task. No care plans. Whenever you need to develop a care plan, that needs to be done by a registered nurse, not an LPN, not an unlicensed assisted personnel or CNA, okay? Perform or develop teaching. What can an LPN do regarding teaching? They
can
can
reinforce.
They can, exactly, good. They can reinforce the initial teaching, but they never do the initial education of the patient. That's an RN task. No admissions, no discharge, no transfer. That's also an RN duty. If a change occur in an assessment, okay, the next assessment needs to be done by an RN. For example, let's say that a patient came for abdominal pain, and this afternoon, the patient developed a very high blood pressure, okay? And the UAP, the unlicensed assisted personnel, to the vitals and tell the nurse, okay, that patient, hello? That patient has 200 over 130 blood pressure. Who is the one who needs to go to that room and assess that patient?
The nurse.
The RN, exactly, the nurse, the RN. Remember that LPNs are also nurses, but they are not registered nurses. They are licensed practical nurses. So they have some kind of limitations regarding patient care. So, and with being said, what LPNs cannot do, what can they do? Well, they can maintain and document IV flow and notify the nurse if something happened. Reinforce teaching, as you said. Do PO orally and IM intramuscular medications, but not the first. I'm gonna give you another hint. The first of anything, the first assessment, the first evaluation, the first set of vitals, the first medication administration, okay, needs to be done by the registered nurse, not by the LPN. Even worse if you assign those tasks to the UAP, to the unlicensed assisted personnel. Okay, never. Whenever they say the first set of vitals, the first assessment, the first medication administration, okay, the first assessment after any change in a previous assessment, that needs to be done by the registered nurse. Okay, they can also do ostomy care. Do you know what ostomies are, right?
Yes.
Exactly. Colostomies, etc. And limited assessments like blood pressure, temperature, bowel sounds, IV pattern, and stuff like that. Okay. Now we go with unlicensed assisted personnel or assisted personnel or unlicensed personnel. They can call it also CNAs, or they give you in Nclex other names. Okay, let's gonna generalize it as unlicensed assisted personnel. Those are the patients that are to assist not the patient, the personnel that are in the hospital to assist with the patients. With the patients, what? What do you think they assist the patient with? Activities of daily living. They just assist the patient with activities of daily living. They assist the patient with that the patient can do him or herself, okay? And also they can do vital signs, but as I said before, not the first vital signs. They can do ACU checks, they can do enemas, okay? And they can measure input and output. Now, regarding input and output, can they calculate input and output? Can they do the calculation? No. They can just measure, okay, and report it to the nurse. And the one who document those findings are the nurse and also ADLS. But be careful with ADLS. If the patient is gonna walk after a surgery for the first time, who is the one who needs to be next to that patient?
The RN.
The RN, the nurse, okay? Regardless, this is an activity of daily living, the RN is the one who needs to be next to that patient, not the UAP, the RN. If the patient needs
Sorry,
to
Professor,
go,
quick question.
yes,
I'm sorry, Professor. You said if the patient is walking but ambulating for the first time
yeah,
after
for the,
surgery, okay.
for the first time after surgery, for the first time after being in a hospital, after
Okay.
being in coma for 20 days, okay, and the patient is now better, so the MD gives you an order to ambulate the patient. This is an activity of daily living, okay, but it cannot be witnessed, okay, and the patient cannot be assisted by an unlicensed assisted personnel. It's the nurse who needs to be next to the patient, okay? But because it is considered anything that is done by the first time in a patient is considered an assessment. And assessments are nursing tasks, okay? So how do you
So, Professor, I'm
intervene?
sorry.
Yes,
Can the LPN walk a patient for the first time or just the RN?
just the RN. For the first time, the RN. Moving forward, the LPN or the licensed assisted person can assist the patient with ambulation, okay? For the first time while being hospitalized, the one who walked that patient is the RN. Are we clear?
Yes,
Is that
sir.
clear? Is that clear now?
Yes.
Yes.
Thank you.
All right, perfect. Now, how do you intervene with inappropriate behaviors of a staff? And that's kind of legal stuff regarding nursing. For example, if you witness an illegal activity like threats, assault, administering medication without an order, what do you do as a nurse? Do you call the police?
No.
You notify your manager. Okay, you notify your nurse manager. That's what you do. If you witness another nurse or whoever is doing something that could be harmful or dangerous for the patient, what do you do in that immediate moment?
You notify the charge nurse?
You would be losing time. If you go to notify the charge nurse, when you come back, maybe it's too late.
You
So
would
you need
intervene
to confront that person and take over immediately. Okay, you need to go, okay, in a respectful manner. Okay, I need you to step out of the room and I will take care of the patient. And then you notify the nurse manager. All right. If not harmful but inappropriate behavior, is being performed by another person, what do?
You confront them first and take over.
No, no. You confront them first and take over immediately if what they are doing is harmful or dangerous. If what they are doing is not harmful or not dangerous, but is inappropriate, for example, disclosing patient information, okay, with another nurse who is not assigned to that patient, is that harmful for the patient? Is that dangerous? It is not, but it is inappropriate. That's a HIPAA violation. Okay, that's not gonna cause any physical harm to the patient, but it's inappropriate. What do you do? At a later time, you talk to them about the situation. Okay, you can stop that immediately if there is no patient in front of them. Okay, so just to not cause a conflict between the patient and the nurse. Okay, if the patient is inside the scenario, you wait, and in a later time, you go to that nurse and you tell the nurse, listen, I heard you talking about patient X with the nurse from third floor med surg or whatever. And that nurse is not assigned to that patient. So you violated HIPAA. Please don't do that again. Okay, in a later time. And what would never be the answer for legal stuff regarding nursing? Ignore it. You never ever ignore nothing regarding legal in nursing, okay? Whenever they say ignore the situation and continue taking care of your patient, you can rule out that answer, okay? That's not what you do. You can talk to them later. You can contact your supervisor. You can confront them and take cover of the patient care, okay? Regarding whatever the situation is harmful, dangerous, it is an illegal activity, it's not harmful but inappropriate, but you never ignore it, all right? Okay, here we have a table of some scope of practice for RNs, LPNs, and UAPs, and for prioritizing of care. So I'm not gonna stop here to read the tables. I'm gonna share this PowerPoint with you. Okay, there is also questions in the Nclex regarding prioritization according to lab values. What are those lab values named? Critical lab values. Do you need to know? Yeah, go ahead.
I know they said you always prioritize potassium levels.
Sure, we're gonna see that. We're gonna see that here, okay? And I'm gonna give you a hint. What is the devil, or what is the devil number? I don't know if you know what I'm talking about. 666, right? 666. That's the demoniac number, okay? Whenever they give you a potassium in the 6, a hemoglobin in the 6, okay? And other values that we're gonna see moving forward here, pay attention to that. Stop right there, because that patient is in danger and you need to do something immediately, okay? There are questions in the Nclex that ask you to prioritize according to lab values, and those lab values are named critical lab values. So do you need to memorize the whole lab values? No, you're not gonna be able to memorize all lab values. But what you need to know and what you need to memorize are those lab values that are critical for the patient. okay? And we're gonna see it right now. Now, when prioritizing lab values, we're gonna follow a strategy that is called ABCD. A, I like to call A as an apple. When you spell a name or when you spell a word, usually they say A as an apple, B as in boy. Okay, what does an apple means in nursing? What does an apple means in nursing? Nothing, right? An apple means nothing in nursing. So whenever you see a lab value that is classified as an A lab value, you do nothing with that, okay? That's the lowest priority. That lab value can be ignored for a few hours and you can wait to report it to the provider, okay? B is bad. B is bad, but can wait, okay? Pay attention. B is bad, but can wait. This is a low priority, so all that you need to do is closely monitor the lab value and monitor the patient. Nothing else. You don't need to call the doctor at 3 a.m. in the morning because the patient is having, let's say, a high creatinine level. What do you think that the provider is gonna do with a high creatinine level at 3 a.m. in the morning? Nothing. That can wait until the morning shift report, okay, to be notified. So you don't need to call the physician at 3 or 4 in the morning to tell them, listen, I just got a call from the lab and they told me that the patient has a creatinine, I don't know, the creatinine is high. No, you don't do that, okay? Now, if the laboratory calls you and tell you, listen, patient on bed 204 has a potassium on 6.7, you need to call right away at 3 a.m. in the morning to the doctor to notify that lab value, because that's critical, okay? C means critical. You need to do something with that lab value, okay? It is a high priority. You need to report, but before reporting to the patient, to the physician, you need to do something before reporting. And D, and the last classification means deadly. You cannot go out of the patient room if they report a deadly lab value to you. You need to go to that room, stay with the patient, have someone else to call the doctor, okay? But you need to stay with the patient and do something with that patient. You need to have someone else to report the provider immediately, but you cannot abandon the patient. You cannot let the patient alone at the room. Now, the change of action. What is the change of action for critical lab values? First thing to do is hold. If there is something to hold, if you need to hold some treatment that maybe is the cause of that critical lab value, that's the first thing you do, okay? You hold, for example, the next dose of coumarin, right? Just to give you an example, you hold the next dose of coumarin in a patient with an INR 2 to 3 times the normal value, okay? Or when 4 or above, you need to hold coumarin, okay? And what is the next thing that you do after holding something? If there is something to hold, you always assess the patient, okay? Okay, I got that lab value. I got a call. Let's say that I got a call from the laboratory in the hospital. And they tell me, listen, this patient has a potassium, okay, to go with the same example, a potassium of 6.6, and the patient has a potassium drip, okay, what the first thing that you do? What the first thing you do in a patient with a potassium in 6.6 or 6.7? You hold the potassium. You hold the potassium because if you give him more potassium, you're gonna kill the patient. Okay, you hold the potassium. Then you go and you assess the patient. What do you assess in a hyperkalemia? What do you assess?
Arrhythmia first.
Exactly. Exactly. You look for cardiac arrhythmia. So do you assess the monitor? The patient is usually monitored, okay, to see the ECG if there is any kind of arrhythmia, okay? Then what you do? What is the third? You have it here in front of you. You prepare to do something. If there is something to do,
Prepare medication in case that the
exactly.
doctor give me the order, insulin
Exactly.
in this case.
Exactly. If the doctor gives you the order, but if the doctor doesn't give you the order, you prepare to give insulin. What does preparing mean? You locate a medication, okay? You have any supply that you need to administer that medication, and then you call the doctor and notify the doctor. Listen, I have this patient with a potassium drip. The laboratory just reported me that the potassium level in the patient is 6.6. I already hold the drip, okay? I look at the monitor, and the patient is having arrhythmias. I have the insulin ready. What do you want me to do? And the provider is going to tell you, okay, give the insulin to the patient. Okay, that's the chain of action to follow in critical lab values. Okay, the pH. Whenever they say a pH in the 6, which is a critical, what is that? Lower than 7.35.
Acidosis.
Acidosis. Okay, that's a critical acidosis. That's deadly. Okay, that's incompatible with life. Okay, if you see a pH in the 6, that's immediately level C, that has the highest priority. As I told you at the beginning, 6 is the devil number. Okay, whenever you see potassium on the 6, pH on the 6, hemoglobin on the 6, that's immediately a level D lab value. So that's deadly. That's the highest priority. Okay, you need to stay at the bedside of that patient. You cannot let the patient alone. Okay, you need to have someone to report to the provider, but you cannot let the patient alone. Okay, if you see a patient with a pH in 6 point, let's say 6.25, do you hold something? Is there something to hold? Nothing, right? There is nothing to hold, so you go immediately to assess. What do you assess? Vital signs. You take a set of vital signs, okay? Because you need to report something to the provider, not only the lab value. You need to tell the provider, I did this, this, and this, okay? I took the blood pressure, I took the respiratory rate, I took the heart rate, and it is and these are the values, okay? What do you prepare to do in a pH in the 6? Nothing. You don't prepare to do nothing, okay? So if you see a pH on the 6, you hold nothing, you assess the vital signs, you call the provider, okay? And you don't call the provider. Actually, you don't call the provider. You stay at the bedside, you have someone else to call the provider because you need the provider to be at the bedside immediately. You need the provider there immediately with that patient. All right? The BUN. Is the BUN a high priority lab value? It is not, okay? BUN, or blood urea nitrogen, means waste product in blood, okay? The normal values are 8 to 25, but it is a level A and has the lowest priority. You hold nothing, you assess for probably dehydration, and you prepare to give IV fluids, and then you call the provider, okay? So, but it is not a high priority. Now, the hemoglobin, and pay attention to the hemoglobin. Depending on the values, you're gonna classify the hemoglobin on level B, C, or even D, okay? If the hemoglobin, and I know that there is kind of changes regarding the age of the patient and even the sex for hemoglobin. But I want you to memorize something. Whenever they talk about hemoglobin, 12 to 18, okay? 12 to 18 is the normal range. No matter if the patient is a child, no matter if the patient is a woman, no matter if the patient is an old man, 12 to 18, okay? Do not complicate it too much, 12 to 18. If the hemoglobin is 8 to 11, then it is a level B, okay? If it is less than 8, it's a level C, and you need to hold what? What is causing that hemoglobin being in 7.3? Nothing. Okay, there is no intervention that is causing that hemoglobin going down. So you don't hold nothing. You assess for what? What could be the cause for low hemoglobin, for anemia?
Bleeding.
It could be bleeding. Okay, it could be malnutrition. Okay, so and you prepare to give blood, and then you call the healthcare provider. Okay, what does it mean by preparing to give blood? What do you need to know before giving blood?
Blood type, religion.
Exactly. So you go to the patient chart and you check for the blood type, okay, before calling the provider. Because when you're gonna call the provider, you're gonna tell the provider, okay, the patient is O positive, has an hemoglobin level 7, and needs to get a blood transfusion. You can give recommendations to the provider, okay? You being a nurse doesn't mean that you cannot recommend a provider what to do. You tell the provider, I think that a patient needs to get a blood transfusion because the hemoglobin is in 7, and the patient is pale, has rapid respirations, is desaturating. Those are collateral symptoms of anemia. So you give the report to the provider and you recommend what to do to the provider. Okay?
Can you request a prescription?
Can we what?
Request
Request what?
a prescription.
Sure. You can request it. Do you mean request to the provider?
Yes.
Yeah, sure. That's what I mean. That's what I mean when I said to give recommendations. Okay. You can tell the provider, can you order 2 packs of of blood to this patient to be given now, the provider is going to tell you, yes, of course. Okay, I'm going to put the order right now. Because usually you are the one who are at the hospital and the provider is probably at home on call. Okay? You are the one who is seeing the patient. And if the provider doesn't give you an order that seems logical and that seems accurate for you, you have the right to discuss that order back to the provider. And if the provider continues telling you, I'm not gonna do that, and you think that what the provider is ordering you is not the best option, then you go back to your supervisor and you talk to your supervisor. Listen, I call the provider is telling me not to do this, and I do believe that the patient need this, and this to be done. That's enough, the patient would die. And your supervisor is gonna take care of the rest. Okay? Okay, let me see. Okay. Okay, I want you to see this. Those are the 5 Ds regarding lab values. The potassium, more than 6. The pH in the 6. The CO2 in the 60s. The PO2 in the 60s, and the platelets less than 40,000. Okay? So you have 4, 6, potassium, pH, CO2, and PO2. Okay? The Nclex will never put them together in the same question. Never. Because you cannot prioritize between a potassium in 6.1 and a platelet in 20,000. It's the same level of risk. They are all level D, so you cannot prioritize between one and the other. You need an RN at the bedside for both patients, and you cannot divide in 2 RNs. All right? All right, guys, let's gonna take a short break, 15 minutes break. And then we will be, if that is okay for you, we can answer Nclex type question from Archer regarding prioritization and delegation. Noaria, you have your hand up. I'm sorry, I wasn't seeing the chat down.
I'm sorry, this happened by accident. Sorry.
All right, okay, no worries, no worries. Question, guys, I know it could be some kind of difficult to get it all together in a shorter time, okay? So I try to summarize what do you need to know the best. And then, but the best way to do this is answering questions. And that's what we're gonna see, we're gonna do next, okay? So if you are okay, we can get back at 7, let's say 7:20, if that is okay for you.
Okay.
If you have things to do, that's okay. We can stop here and then come back at, I don't know what time. Tell me, what do you want me to do?
I think a small break is okay.
Okay, so let's gonna take a small break so you can, maybe we can eat something and then go back at 7, let's say 7:30. Is that okay for you?
Okay.
Okay.
That's
All right, see you 7:30, guys. I'm gonna be sharing here, let me see. So you can see what we're gonna do next. Okay. All right. So we're gonna be answering questions and answers from Archive Review, all right?